Hello and welcome everyone to the Menzies School of Health Research Youth Onset Type 2 Diabetes Case Study Series 2023. Session 1, we'll be focusing on children today. And the Youth Type 2 Diabetes Project is part of the Diabetes Across the Life course, Northern Australia Partnership, which is a larger research group at Menzies School of Health Research. So as always, I'll start today with an acknowledgement of country. So here in Cairns, where I'm calling from, that's the Gimuy Wallaburra Yidinji people. So I just want to pay my respects to their elders past, present and emerging, and to all the lands on which our viewers are joining in from. I also want to acknowledge the important role that Aboriginal and Torres Strait Islander people play in the work that's done here at Menzies, whether that's as researchers, project staff, participants, or helping to guide our research agenda. In terms of how's today going to run with the case study series, we're going to have 3 case studies and they're going to run for about 15 to 20 minutes each, we estimate. How that's going to work is I'm going to read out the details of the case study, which the panel will then discuss. I'll have a couple of questions, but I'd also really encourage the audience to type in questions. So we've got a Q&A box down the bottom, which you can see. So type in your questions there, and you can also upvote the questions that you'd most like asked. And that's a good way to interact with the case studies that are happening. So you can get the questions that you've got asked and answered. So our panel today, we've got 4 panel members today. So we've got Emma O'Connor. She's a child health program lead, a remote area nurse at Mitawaj Health Aboriginal Corporation. We've also got Samaria Corpus. She's an Aboriginal health worker / diabetes educator at the Royal Darwin Hospital. We've got Stuart Mobsby, nurse practitioner at primary / complex care for NT Health. And we've got Dr. Angela Titmus, paediatric endocrinologist and paediatrician, also researcher here at Menzies School of Health Research. So, and a special thanks to Samaria and Stuart, called in on very late notice. We've been trying to get speakers from each region that we work in. So the Youth Type 2 Diabetes project that we've got works across 4 different regions across Northern Australia, Far North Queensland, where I am here, also the top end, but Central Australia and the Kimberley as well. So we've been trying to get speakers from every location so that we can, I guess, have a good diversity across our panel. As you can imagine, that's difficult logistically to get clinicians who work in this area who have time to do this. So thank you to all our panel members today. So I guess there's a little bit of a disclaimer. These case study series, they do contain de-identified information and they include factual and fictional information. And the purpose of that is to highlight important aspects of care and learnings, but also keep any details that may be factual, private and confidential about the places that we could have gotten this information. So we'll start with case study 1. I'll just move my screen a little bit so I can see all the details. Okay, so case 1, we've got a 7-year-old boy diagnosed with type 2 diabetes after being screened with HbA1c due to obesity. He's got a BMI Z score of 3.2 and a waist to height ratio of 0.6. Acanthosis nigricans, HbA1c is 8.9%. When we look at the family history, he's got a mother with type 2 diabetes in pregnancy and a father with type 2 diabetes. Multiple aunts and uncles are affected. He's got 5 siblings, 2 of which have developed type 2 diabetes in adolescence. Looking at the social history now, he lives in a remote community. This is 400 kilometres away from Darwin. Irregular school attendance, family mobile, they're moving between different communities, experiencing some food insecurity, and also a history of trauma. In terms of comorbidities, he's got RHD, but we note here that he's got excellent adherence with the medication for that. On examination, as mentioned before, BMI Z score is 3.2, waist to height ratio is 0.6. Acanthosis nigricans, blood pressure is borderline for his age, and large tonsils. When we're looking at the pathology results now, we've got LDLs elevated, HDLs lower than what we'd like. Looking at the liver now, we've got ALT looking a bit high, AST a bit high as well. And then looking at the albumin to creatinine ratio, again, a bit high there. So I guess passing it over to the panel now, starting with yourself, Angela, what would be your priorities for care for, I guess, the healthcare team and also for the family and patient? You're just on mute, Angela.
Sorry about that. I think really you need to know from the family, and I'd be talking to the staff at the local clinic, also like the AHPs particularly, or community workers at the family who know the family well and what might be priorities. Obviously, there's a huge history of diabetes in the family, and so that in itself can change a family's reaction to the 7-year-old then being diagnosed with diabetes, and really trying to explore what diabetes might mean or look like to the family, and therefore thinking about that will help us to determine what might be the engagement points or the priorities of care to better link this family in. Obviously, they have engaged well with despite other things that are going on in life, with the rheumatic heart disease diagnosis and the management of that. And so it's a point of potential opportunity to then work with. But in terms of just thinking about from a medical perspective, he's obviously at very high risk. He's a young boy, less than 10 years of age, diagnosed with type 2 diabetes, very strong family history and in utero kind of programming of that. And he's already got comorbidities evident. One about fatty liver. It looks like he's already got some proteinuria. He possibly may have sleep apnea related to obesity and the comment about his large tonsils. So we do need to quite quickly get on top of lots of different aspects of his physical health, but then really need to explore what's going on in the background and the social determinants and food insecurity and other vulnerabilities that the family may have.
Thanks, Angela. I might pass over to you, Samari. When you've got someone coming through your clinic, they're 400 kilometres away is their home community from Darwin. What kind of things are you thinking about here?
You look at the family, talk to the family, try and get an understanding where they're at. Where there's no point just talking to this boy, just talk to the family and see the dynamics, and maybe set up an education where the whole family's there. Because the other siblings, the mum and dad's got diabetes, so do like a family group education. That would be my point, because the young fella, he's not making the meals.
Yeah.
So the mum is. So maybe small changes with the family's attitude towards sugary foods and drinks would be a start. Just set small goals and build. And find out why they're going to why they're involved with the rheumatic heart and what makes that work for them. So, yeah, I think just working out the family dynamics is the most important thing at the beginning.
Yeah.
Yeah.
Would I be right in thinking that establishing a good relationship here is absolutely crucial?
Yeah, building that rapport, building that trust. Yeah, so yeah, a lot of people turn off if they don't if you come across too strong.
Yeah.
Or the first time they meet you, like it takes a while to build up rapport. So that's the only way we're going to get ahead with these young people, is just understand where they're coming from and build that rapport. And then build on getting them to change small goals, small things in their lifestyle. Otherwise they get overwhelmed, frustrated and walk off, and we won't see him for another 12 months.
Yeah.
Yeah.
And I might throw over to you now, Emma. I'm interested to know you work in remote areas, as I understand. What kind of things would you be thinking about with a patient like this in terms of priorities for care?
Hi. Well, look, I think I agree with both what the other two ladies have said. And I guess also just understanding where the family's at and understanding in the environment in which they live in and what their capacities are to build the change. And I guess from a clinic point of view, you know, we're always quite under-resourced, so tapping into the other communities, strengths and stakeholders that can provide some wraparound support and services, especially in East Arnhem. There's a lot of groups that can help adolescents and young families within the community to try and help them with education and, you know, food vouchers and going to the shop and cooking lessons and things like that.
Excellent. Yeah. And Stuart, have you got anything to add here from what's been said?
Well, I agree with everything that's been said so far, but I think, yeah, the engagement is the priority here. So thinking long term, I think if, you know, you get a result of a HbA1c of 8.9, we can get ahead of ourselves of thinking about that number and trying to bring that down. And I think, like Samara said, you know, you can start to scare people off really. And if you're not focused on the family and really prioritizing that engagement.
Absolutely. And I'll move on to the next question now. So Angela, who do you think should be involved in the care here?
I think it's very much like what Emma said, it's involving a wraparound support, and that's where I've seen it work the best. So there's a lot of opportunities to think about how we could increase support for this particular family. Like this young boy has had limited attendance at school, but school is obviously a point of resilience and can assist. And we have lots of children and adolescents that are really assisted with their health issues through remote schools. And so that would be a point also that helps in just building his general kind of resilience and strengths life, and thinking about what other support we can provide to the family, whether it's, you know, thinking about food security, thinking about family support that when there's that trauma history as well and what might be needed, looking at housing. So I think it's really thinking beyond the health sector to see how we can reach out to multiple services to be involved in the care of this young boy and really help with the support of the family.
Yeah, definitely. Samara, any thoughts here in terms of who should be involved?
Well, normally in a community setting, there is some people that relate to, you know, the local health worker, support worker, local nurse, whoever has got rapport with them or, you know, can work on small changes, you know, because we look at a HbA1c of 8.9 and everyone freaks out. You know, that's better than 10, but I think we have to simplify how we're going to do it, you know, how we're going to tackle the family.
Definitely. It brings up something that I'm wondering about when I see that, and perhaps Stuart and Emma, you could comment on this, is, you know, sometimes you have someone come through the door first time and you could see opportunities for multiple people to be involved. And I wonder what you guys think about when to involve them and who to involve, and if we can sometimes overwhelm people with maybe too many supports too soon. I'm interested to get your thoughts on that. Perhaps Stuart, I'll start with you.
Yeah, and that's probably the point that I was going to make, is that there's a lot of people that do need to be involved, but it's about the timing of that involvement. And I think it's just to build on, again, on what Samara's just said, is finding that right person to be the connection with the health service to start with, the person that has the relationship, the rapport and the trust, and with the support of the rest of the team working towards those goals of care. Because obviously having a lot of people involved can be quite daunting and quite confronting. And we do need to give time for the child, but also the family, to come to terms with that diagnosis and to work through what they feel is going to be important early on, moving through that care. So yeah, it's lots of people involved, but not overwhelming, and just having that person that can be the connection point and finding the right person to do that connection.
Yeah, definitely. And Emma, what are your thoughts on that?
I agree with Stuart. I think I don't have much more to add. I think it's really important to just see where the family's at, and then you can discuss with them what sort of services they want involved. And I think it needs to be very slow and at a pace that suits the family.
Okay. I'll move on to the next point here. And Angela, I'll go to you on this one. Medically, where are you starting here?
Yeah, and I think it's what Stuart and Samara have said. What we would like to happen is not necessarily the right thing at that time in terms of thinking about what we're trying to achieve for long-term outcomes. And obviously the long-term outcomes is that we're wanting to optimize the glycemia, we're wanting to prevent long-term complications and manage comorbidities. But if you try to do all of those things initially, you may not achieve any of that in the long term. I often think it's kind of a balance, though, however, in making the health services that are looking after this young person realise the difference between youth onset diabetes and adult onset diabetes, and for them, the health professionals and the health team, to see it as an urgent and important thing, but then working out how we engage the family so that we don't disengage and that we don't overwhelm. But it's, I can't remember who said it, but if you give too much information, it can be overwhelming for a family at that time. But that's not an excuse for us not to act, I suppose, or for the health team not to be making this a priority. But we have to work out the right way that can really help and engage and work with a family. And so if you're talking about just medical management without kind of considering those issues, if they're in a world where there wasn't complexity, then we'd be talking about that this young person obviously needs metformin. We need to be, the HbA1c is high, they need insulin to really bring down those sugars, and we need to look at what might be the drivers of high sugar, such as sweetened beverages particularly. But in a world that is full of complexities, we have to sometimes work out strategies around each of those things and how we can work through those things in a way that really engages a family.
And can I ask you, Angela, in terms of the insulin, would you have any preferences there in terms of basal, bolus or mix?
Yes, I never use bolus insulin in this situation. I don't think you're going to get any family, or very few families, I suppose, that would do that. And we're not talking about, in this kind of case of 8.9%, I imagine he would probably not be on insulin long term. We'd be talking, and that's sometimes in itself a positive way to describe it to families, is that we can optimize your sugars quite quickly by bringing insulin in while we're titrating up metformin, because we'd have to titrate up the dose, optimize the sugars, and then the insulin is often, and we're often only needing it for, say, maybe 8 weeks, 10 weeks, and then able to come off insulin if we optimize those sugars really quickly in that initial period. But that requires really good engagement and support with the medication, because if we're not taking the medication, then insulin is going to take much longer and it's never really going to get the goals that we're wanting. But I see many families where they really take that on board and yeah, we could bring them off insulin within probably about 2 months.
Mm.
In this kind of situation, a 7-year-old, 8.9%, that's probably what you would be predicting would happen. But you always have to explain to family that that's not a definite, but that's what we would be kind of hoping would happen. And the only other thing I'd say is that metformin, a 7-year-old, it's really hard to take metformin. They're big tablets, as all of us know. It's they have side effects. It's not a pleasant medication and it's hard to swallow. And so I think you have to really explore how we could possibly take metformin and who can support him to do that. And do we use, usually I use extended release because it has less side effects, but the tablets are bigger. So often having rapid acting and crushing it in milk, for instance, or yogurt would be a strategy that a young boy can actually do and take. And I have many young people who would much prefer to take insulin than take metformin. So I think I know I personally would prefer a tablet to an injection, but many young people tell me they'll prefer an injection to metformin. It's very much a disliked medication.
Mm. And kind of following up, Angela, obviously we want to sort out things, the glycemic control pretty quickly as soon as possible with that. If we're looking a little bit longer term here, are there any other things that you're looking for? You mentioned there's a question marks around perhaps sleep apnea, the liver.
And I suppose thinking about what the priorities are. Like if his that one of those comorbidities might be the thing that the family are worried about, or that he's worried about. It's because he may not feel any symptoms of his diabetes, and a 7-year-old may not have the insight to kind of notice the changes in his body, and that those other comorbidities might be something that you actually work on very early on as well. I am really worried that he's got proteinuria as well, so I'd be wanting to kind of investigate that further, thinking about managing his blood pressure. And so that'd be like probably leaning, if that's a persistent borderline blood pressure, kind of adding in an ACE inhibitor to try to manage his blood pressure. But you're wanting to look at general lifestyle management. Like how can we, what are the barriers for him to moving more, for instance, or reducing? Can we do small goals of reducing some screen time? Is that, how could we increase incidental activity? And obviously, yeah, we're really working on what lifestyle, other things like such as sweetened beverages. Can we switch to no sugar beverages? That often is a really big driver. And I've seen many young people where the thing that has turned their diabetes around is the switching of their sweetened beverages, and that's led to a dramatic drop in the HbA1c. It really is a big driver for hyperglycemia.
Definitely. Okay, I'll pass over to the other panelists here. In terms of engagement strategy, I think we've talked a little bit about that already, but has anyone got any other thoughts on engagement strategies for this patient?
I would just say, just think outside the health. We've already mentioned about outside the health service. We can think about engagement points through youth-related organisations. So there's even in remote communities. So I think about organisations like Clontarf, but there's also other organisations that we can think about as an opportunity of engagement as well.
Definitely. And Samara, you mentioned obviously the family's key here too. Is there any, generally speaking, any particular member of the family that you're looking for? Any, I guess, good tips there?
I just encourage more hunting and gathering, get them out in the country and, fishing, and just encourage more activities. And, you've got support workers and care coordinators out there in some areas, just sign them up, for a weekly visit, or get a support worker doing going to the local shops with them, and just encouraging them, healthier food intake, that sort of thing. Because, we can't change if we don't know about it.
Mm.
You know what I mean? And Indigenous people, they learn really fast by showing, by practical. We talk about theories of everything, but they learn faster, practical, showing photos, and like, I believe in simple ways of label reading. I think Baker IDI, anything with the big tick, it's good for you, the healthy heart. I think food should have more of that on, especially out in the communities. Because, if people don't know, they can't change.
Mm.
Yeah.
I really liked what you said there, Samara, about, I guess, some of those cultural activities, getting out on country, hunting and gathering. I guess that brings us to our next point about some of those resilience factors.
Yeah.
Definitely. And Angela, you mentioned previously good adherence with the RHD medication. So there's some opportunities there and strengths to build on, I think. I'm just mindful.
Damien, sorry, can I just answer some questions that have come up in
please. That's where
Q&A?
I was going to go next.
Yeah, okay. So hopefully I already answered about the metformin. So you can't crush the extended release, but you can crush rapid acting, and pharmacists advise so you could crush it in milk or yogurt. And we found that does work, and also can sometimes take the taste, because the taste can be more of an issue in the rapid acting compared to the extended release as well. So that is one strategy around metformin, but obviously then it's the rapid acting, so you'd need to give it kind of twice a day, depending what dose they're on. So another question was asking about teenagers' HbA1c, which we will come to in other cases in the case study. And I suppose the question was, are we allowed to get more excited? I do want health staff to be really concerned and see youth onset diabetes as something that we need to act on, and needs intensive support and needs urgent support. What I suppose, and my point that people, I suppose, were talking about is that we also need to think about how we actually engage if we're in that, especially that very first day when we give a diagnosis. You have to be really careful that we don't turn off someone from coming back. And so we need to kind of make sure we've got the right family members, that we think about how we explain it in the right way, and really get the family on board to also see this as an urgent issue that we need to address. So, I want health staff to be worried, and we're not telling people not to be worried, but you just really need to think about how we work with a family. Yeah.
Any other questions in there, Angela? I think there was one question about a GLP-1 agonist.
So it would not be first line to use a GLP-1 agonist in any guideline around the world in a young person. Just so we do have some emerging good evidence about the use of GLP-1 agonists, and we definitely do use it in children and young people, but it's not first line therapy, and we still have limited data about long-term safety profiles, I suppose, particularly in the youngest kids, such as this 7-year-old. So particularly in children, I think we have a lot more comfort with kind of puberty age kids, but we wouldn't be the standard therapy. So I wouldn't use, again, I see that you've said about with metformin, I wouldn't use that as the first line. The standard guideline would be, in this situation, metformin, insulin, lifestyle, and then thinking about how things go and work out what we do. So I think we need to work with a family, and sometimes I think we make assumptions that something's not going to work, and I've been guilty of that myself. And families if people engage really well and the right family members involved that really see it as an issue, can make substantial changes in a rapid period of time. And I've seen that with a young person that we were going to start on insulin, but by the time they actually came to hospital to start on insulin, they had made such dramatic lifestyle changes as a family from the remote community that he didn't need insulin anymore. He could be managed well just on metformin. And so I think we need to, and obviously the remote health service in that community had done an amazing job of engaging and really working with that family to get that result. And so I think we should be following what are the recommended guidelines, and then working through a process and balancing risk. And I think in a 7-year-old starting on GLP-1 agonist, you do need to be having a discussion that it's off-label, even if you're using it as a second line, like down the track. Families do need to be kind of aware of that it is off-label.
Okay, thanks, Angela. Mindful there's some great engagement, great questions and conversation happening in the Q&A. I'm just mindful of time, so we'll move up onto the next one. So we've got case 2, so I'll read this out for you. So we've got a 4-year-old girl here, HbA1c 6.8%. Looking at the background, so known to child health from 2 years old for obesity. So workup, nothing there to, I guess, of particular note. She's had long involvement with the dietitian. Birth weight was 4.3 kilograms, but otherwise normal pregnancy. Cholesterol's borderline, again, 300 kilometres away from a major centre. Looking at the family history here, mother with type 2 diabetes in pregnancy, father type 2 diabetes, 3 grandparents with type 2 and 1 with type 1. On examination, BMI's 32.9, so Z-score, that gives you 8.5. Borderline blood pressure, marked acanthosis nigricans, marked central adiposity, normal developmentally. Looking with the family here in terms of their fears, medication, diabetes in a young child, obviously. Will it go away? It will go away. Questions there, and stigma. If we look a year down the track, so represented as a 5-year-old, HbA1c is 10.5% now. Still marked acanthosis nigricans. BMI Z-scores improved since last time, but I imagine that happens with growth. Central adiposity, positive autoantibodies, you can see there, but C-peptide's normal. So looking at the questions here, so Angela, I'll pass over to you here. What are your thoughts here with the diagnosis?
Actually, if it's all right, I might pass on to Stuart, as he knows this case well. Yeah.
Please, yeah.
Thanks, Angela. Yeah, this is, I don't know really what to say, but yeah, what we think about diagnosis, obviously there's a bit of a journey along for this client. So earlier on, the HbA1c was 6.8, then with the rapid rise with the representation at 5 years old. So really, with those positive autoantibodies, it's not a clear-cut type 2 diabetes, but probably more, I'm just trying to think of the words, like a mixed diabetes or hybrid, would you say, Angela?
Yeah, I agree. Yeah.
Yeah, and with that normal C-peptide. So, but I suppose really thinking about those approaches at this point, like we previously discussed with a HbA1c of 10.5, we are going to need to rapidly, we need to start metformin and insulin, and really there's, I suppose, really a quick involvement with Angela to make sure, we can have an admission to start that insulin. I don't know, Angela, do you want to add anything else there?
So I think this case, I think, highlights some of the complexity of diagnosis and also working through fears. So this young girl was known to various people and had been of concern to lots of different people for quite a long time. But there are a lot of fears from the family really about a diagnosis of diabetes and medication, and feeling that it'll go away and that it's not something that's, and so I think it been challenging in a way to people to kind of necessarily see her in the health centre, as the family then really kind of disengaged in some ways from seeking healthcare because they were worried about diabetes. And so you kind of, if you don't talk about it, it doesn't happen, I suppose, in that kind of sense. And it was only when, things kind of, the HbA1c really increased, and they agreed to come into hospital. And that's actually, so when they came into hospital that first time, which I think is kind of the next slide, but just to point out, so we thought, metformin and insulin based on this HbA1c. Yes, there's this grandfather with type 1 diabetes, but phenotype fitted more with type 2. And we took antibodies, but obviously they're not back during an admission, so you don't have those results during an admission. We started her on metformin and tiny doses of insulin, and she promptly had hypos in the admission, even on minimal doses of insulin. So we stopped all insulin within a few days of her admission, and her sugars were well stabilised just on metformin. And the family engaged really well with following a meal plan that the dietitian provided. And actually, the HbA1c from that 10.5% at diagnosis, also at presentation to hospital, for about the next 9 or 10 months, the HbA1c was below 5.5, below 6%. They very much were very well controlling her glucose levels, and the family were really engaged with the remote health service with that. But we had told the family in follow-up after that first hospital admission that the antibodies were positive, and we knew that this grandfather positive, and so just to, I suppose, be aware that we were worrying that there is a risk of her developing type 1, but we thought at that time we thought she had type 2. She then represented about a year down the track with a rapid HbA1 rise from like 5.5 up to, correct me if I'm wrong, up to about 12%, I think, Stuart, in a few months.
Yeah.
And we then thought she had type 1 as well as type 2. Quite a mixed phenotype, but just for us to be aware that type 1 can occur in Aboriginal and Torres Strait Islander young people. And we really do need to be thinking that when a young person presents with hypoglycemia, we need to be excluding type 1, and we need to do a really good workup of doing antibodies, doing a C-peptide, really looking at their phenotype, looking at the family history, so that we can be sure on what the diagnosis is and therefore what the right management is.
Yeah. Obviously a complex case medically. I'm just thinking too, obviously there's a complex family situation there, and the communication's really important. Samara, have you got any thoughts in terms of, obviously there's some fears there for the family around medication, and, maybe with the diabetes thinking it'll go away, as well as some shame there. What kind of things would you be thinking at approaching this case and your communication with the family?
Well, this sort of case, like not at such a young age, it's popping up all the time. So we have got young people on insulin. They're not a type 1 or a type 2. They're in that T3C sort of thing. So yeah, just little steps, like, in this case, you'd say, we tried metformin. Everything went up. Now we have to try some insulin, and just using diagrams showing on the pancreas and how that's not working, and they need to inject the insulin. Just delivering the information slow at their level where they can take it in. We never tell any of our clients the diabetes will go away. So what we say is the diabetes is manageable. You can manage it and feel good and live to a healthy age. So we never practice saying your diabetes is going to go away, because it won't. So yeah, but with anything, it's just taking it slow, step by step. And sometimes you have to tell them the story 3-4 times until they get it. That the penny won't drop straight away. So just revisit and, just encourage them, the whole family to eat healthier. And take their medication. we have some kids, they just they hate the diabetes in their life. And then it might take them 2 years to actually say, oh, I feel better. With taking the medication, sometimes the penny drops and then that patient feels better, so they'll take their medication. With diabetes, taking their medication, it takes a long time for people to realise they've actually got more energy. So, yeah, it's just a slow process and small steps, especially at this age.
Definitely. Emma, I'm wondering for yourself, obviously, as Angela mentioned, it sounds like a hospital admission was the turning point here in terms of getting the management practices in place, but long term, we're looking at managing this out in the community. What kind of strategies would you be thinking of out in the community to support someone like this? I'm sorry, it looks like we've lost Emma. I'll throw that question over to the other panel members in terms of perhaps some longer term community management. Any thoughts there?
I might just add a couple of things to this case study, if that's all right, Damien, because there's, I think, just really backing up on some of the other discussions, but this case is really about it's about the family and how you're actually engaging with the family as a whole. So with the young child of having a diagnosis, like you said, there was a lot of shame, and specifically around the mother who had worked incredibly hard on her own management and struggled quite hard to even get her glycemic control under control. But then to feel, it was the importance of the language as a health professional, really thinking about, okay, well, how do we talk about this, that we're not going to add shame to the family about a child that, when we look at the family history, it's devastating history when you look through who has diabetes, and that through our language we can all unintentionally be blaming, and I think we have to think very carefully, and it's about engaging not just the immediate but that whole family, and working together about what steps we can do and to maintain that blood sugar control. And even when the blood sugars went back out of control again, making sure that the language that we were using was really firmly away from blaming, because I think early on, even the fact of the child coming to the health centre and being weighed every time, and the language, the conversation that followed from being weighed. So planning care, planning when weights would happen might be a valuable tool, who was actually doing the weighing and things like that. So just, I suppose, managing the language as a health professional to make sure that the language we use is not blaming carers or families.
So important, yeah. Angela, have you got any thoughts here?
No, I think the positive outcome of this family is really a reflection of Stuart and some other key people that are involved in the care of this patient in remote community, because they really built trust and relationship with this family. And then when things did escalate, the family trusted and moved with what the recommendations were from the health professionals that they trusted in their community. And so I think it really is a reflection of the positive things that they did.
Definitely. And I'm just looking here, there's some questions in the Q&A. Angela, do you want me to read some of them out, or did you want to go through and have a look if there was some that you wanted to comment on?
Yeah, so first, some people asked again about metformin. We did start metformin on this young person, I think it was 250 milligrams that we started thinking to titrate up. And when she kind of came in when it was at 10.5%, and we actually met her for the first time at that point. I didn't have an issue in starting metformin. Obviously, we don't usually use it in that young age, but you also need to treat. And she clearly had a phenotype of type 2, and it was only about a year later that she really then developed type 1 diabetes, that we always thought she was at high risk because of those antibodies. And so for her, we were using rapid acting, and half a tablet rapid acting she could actually swallow. But yeah, you could also crush if needed. And she actually only needed a very small dose and seemed to be very sensitive to that. And then we were actually able to stop metformin after about 6 weeks. And she really went from 10.5% down to being in the 5s and stayed like that for almost 12 months in terms of HbA1c. So she had quite a dramatic response to treatment and changing food within the household, which the whole family did actually. So the other questions people were just asking for the dose. So yeah, I don't think there's any great guidelines that suggest for metformin for age and weight, but in a child like this, I'd start at kind of 250 and move upwards and see what we get to. And trying to minimize side effects. I think you're always going to have a ceiling from the side effects, and it's going to be a lower ceiling in a smaller child. And just the one other question that people talked about was insulin happening early and possible. And I agree with that. I think I often see young people where their initial HbA1c was quite high at a point where we should have started insulin, and it didn't, because people were kind of worried about bringing that in. And I acknowledge the workforce pressures that Emma's already mentioned, and hugely understaffed primary healthcare staff. So it can be a really difficult thing to start remotely. We're always happy to admit to do that. And sensors can be a really great use as well, and help with that kind of titration. But I think if you're able to start insulin and then rapidly titrate the insulin so that you actually normalize glycemia in itself, that is an engagement point. If a young person comes in and their sugars are in the 20s, and 5 days later or so, their sugars are sitting at 5 and 6, they can clearly see that difference of medication, and it's a motivation in itself for the family to keep going because they see it actually makes an effect. While if you don't see any effect of a medication, why would you keep doing it? So I think we do need to think about how we approach it, and we don't want insulin to be considered a shame. The other thing is that often families think insulin means that my child's going on dialysis because renal patients use insulin, or they're going in ICU and they're going to die, and you're just not telling me that. So you need to be really clear that youth onset diabetes is different to adult onset diabetes. We use different medications. Doesn't mean, and I actually explicitly say your child doesn't mean your child's going to die. Your child's not on dialysis, but this is why want you to use this medication. And the one other thing was about SGLT2s. So again, they're second line treatment. It would be a thought to consider in any young person that has renal kind of complications of proteinuria. But we still have really limited evidence in children or youth about SGLT2, though there is some positive emerging data that's been kind of published in the last 2 years, but it's not first line, would not be something I'd be considering in this initial presentations.
Thanks, Angela. Okay, well, I'll move on to the final case study for today. Okay, we've got just a little bit here on the follow-up, which I think you might have touched on already for this patient. So they started on metformin and off the insulin. Okay, so we'll move on to the next one. Okay, so case 3, we've got an 11-year-old boy presented with a HbA1c of 14%, normal C-peptide, negative antibodies, minimal ketones. Background, he's got RHD, Hashimoto's thyroiditis, moderate intellectual disability, attends special school, BMI is 36.3, waist to heights 0.6. So when we look here at the family history, so Angela, correct me if I'm wrong, but the coloured squares are denoting a relative that's got diabetes. And so you say
yes, yeah, and he's the one in black, and the reddy orange squares are other relatives that have diabetes.
Yeah, so you can see here, obviously, a strong family history of diabetes. Got 2 times uncles, maternal grandmother, mother's on dialysis. So maternal GDM with 3rd pregnancy progressed to type 2 diabetes postpartum by the sounds. Okay, so looking at the social history now, the mother's unwell, she's on dialysis, irregular school attendance, awaiting housing, complicated eating behaviours and obsessions, and 3 to 4 litres of soft drink intake per day. So in terms of the questions here, what would be your priorities for care, starting with a patient that came through your door with this? I'll start with you, Angela.
I think you've probably heard enough from me. Maybe
Okay.
Emma, do you want to start with?
I'm sorry, Emma appears to
sorry.
have, I think her connection must have dropped out. She was tuning in remotely from a remote community. So might pass over to Stuart and then Samaria.
I think, you know, similar to other presentations here, there are a couple of dual prioritizations. So obviously the really high HbA1c is definitely a significant priority, as Angela's already said. You know, we do want to, I suppose, act on these results. Again, we've really got to think about this family, the family dynamics, who's there, the emotional well-being. You know, we've got a mother that's unwell, who's on dialysis. So the social and emotional well-being's a key priority. The medical side of things in terms of getting the blood sugars down, but also understanding who else is in that family and connecting well within that wider family as well.
Definitely. It seems a pretty complex family dynamic and situation, obviously, and then for the young boy himself having a intellectual disability, that's going to add another complexity to management. Samaria, what do you think here? What would be your priorities for care for, I guess, the healthcare team, and then looking for the family and patient?
Well, just getting to know the boy and what he thinks he can achieve. You know, even taking one tablet a day. And we see this a lot, this like family dynamics, and you just chip out one thing at a time. You know, and just find out how the family is. And, you know, like encourage the dad to buy more fruit, cut down on takeaways, talk about how much sugar in one soft drink, options, drinking water, or slow down on the cold drinks, you know, try diet or zero. It's still bad for you, but give them options, you know, say, can you try? And I think everyone should be involved, you know, whoever knows the family in that community. And all it is like education, reassurance, and it's not all doom and gloom. Just try and, you know, like look at some positive things, you know what I mean? You know, get excited. Oh, you went to school 3 times this week. That's great. You know, look on the brighter side. You know, and that just builds someone up to make them feel good. Because this poor kid, if he went to the clinic and someone didn't know him, they'll be saying, oh my God, they'll be freaking out. We try and tell people, you're very naughty, your HbA1c's up. If we can just get them taking their medications, that's a start. Change comes later, but, small changes are better than no changes. There's not a magic wand we've got, but I believe in just small steps and work on positive things within the family dynamics and encouragement.
Definitely. I guess you're not going to get there in a day, are you, in terms of getting things under control with the HbA1c? So I guess taking those small steps and building upon that seems like a really practical approach.
Yeah.
I'm wondering for yourself, Angela, what are you thinking in terms of the medical priorities here and your medical management?
So obviously he's really high risk, and everyone is really concerned about not just for his diabetes, but his other medical conditions and the social situation. And I suppose thinking about that, if his intellectual disability, he's not going to really over the next few years necessarily be able to take on his own medical management. We're really going to need to think about who is a key family member that's going to be able to provide long-term support for him, not just now, but also when he's older. And I'd be looking at the mum having dialysis, and she's obviously linked in closely to healthcare. Can we leverage off that to be able to really optimise his healthcare quickly? Usually dialysis patients have a very close relationship with the renal team, and there's a lot of kind of wraparound support there. So whether that could be used as leverage in terms of bringing him into hospital with mum and maybe another family support member that's well as well, so that she can have things that she can sort it out as well, but that we can really try to quickly work out what doses he needs, because I think that's going to be really, really hard in the home environment, and it's going to make a lot of burden on primary healthcare to work out what doses he needs. And if we can quickly titrate and optimise those doses, then that's at least one complexity taken out. Then the issue is then working out engagement and how to be able to continue medication, but we're at least worked out what the doses he actually needs, and like how much insulin he needs. And then I think it's just otherwise it's going to be really hard in that kind of situation where she's at dialysis 3 times a week. She's unwell herself, about who's going to kind of provide that support and engagement. And this may be a point of motivation for her. Like, I know there's a really chaotic home situation and she's unwell, but she probably does not want her child to be on dialysis. And so it's probably a motivating time in her life where she would, in the context with enough support, be wanting to do everything she could to optimise her child's health, acknowledging that that support needs may fluctuate well over time.
I'm wondering too, I saw in the case notes there that there's some interesting eating behaviours happening in terms of the very high soft drink consumption and also some obsessive eating behaviours. So I wonder if there's, I guess, any room there for, you mentioned in a previous patient, something structured in terms of their meal plan or nutrition was helpful. I wondered for a patient with this type of background if that would be worth trialling.
Yeah, I think that's a good idea. And really for this young person, I'd be trying to link them back into that support, the school that they, the supported school that they go to as well, because this is a, well, you have the staff and the skills to be able to provide kind of structure and routine that may well help a young person that has an intellectual disability with meals and just building that overall structure. And are there any older siblings that, like, how are the older siblings that have diabetes, how are they managing? Can we leverage off them to help look after their younger sibling? What are their beliefs about diabetes? But I think there are points of opportunity And I think people have mentioned in the chat before, I definitely agree about the value of home visits in these kind of settings, acknowledging that that is obviously workforce intensive, resource intensive, but it definitely really helps. And I've seen that services do that. I've had really good success in engaging and working with families.
Definitely. Okay. Any other thoughts, I guess, in terms of the long-term management of a patient like this, or are you just focusing on first things first, just get some of the medications going and some things in place to try and bring down the blood sugar levels?
So there's just one other point in the chat about NDIS, and definitely I forgot to mention that here, but we do that in quite a few young people like this. That's a great potential. Like sometimes I'm actually really glad when someone from a complex home situation, if they have a developmental issue or disability, that actually really helps in us feeling support around them in terms of diabetes, because you could possibly get a support worker, for instance, funded through that. You could look at, sometimes we've been able to get sensors through that for young people with type 2 through the NDIS. So there's definitely opportunities using the NDIS that could provide support in this case as well. And a support worker could, help with daily medication, for instance. So there's opportunities that some of his comorbidities actually help us with. Yeah. But yeah, I think we're not going to win in this situation by just relying on metformin. Unfortunately, we really do need to add in other medications, and we need to work on the compulsive kind of eating behaviours and seeing how allied health team as well might be able to assist with those compulsions and obsessions.
Before closing, any other comments from Stuart or Samaria?
We're getting more, we're talking to the schools more now, so we've got some young people have taken their metformin at school, and that seems to be working as well in the school support worker. So, and even just doing a random blood sugar at school is quite helpful. And so, yeah, their teacher knows and a more understanding, I think. But the young people we have got and talking through the schools, it seems to be working as well. I know the schools are busy and that, but there is support at the school, at school level as well to think about. Yeah.
Seems like it's a captive audience. The structure there seems a really important place to engage with.
Yeah.
Stuart, any final thoughts from yourself?
No, I don't really have anything much else to add. I think as a health, when we work in health services, don't just think what's within those walls about what's available. We think about, what community resources are available, and that doesn't really change whether you're working in a remote community or within an urban setting. There's always some resources that you can fall back on to support the actions that we do within the health service. And I think specifically with young people, think about youth groups, but also, in this case, thinking about, NDIS, the school is definitely a key component moving forward. So it's always looking a bit further than the health walls and looking into the community.
I agree.
Definitely. Angela, any final thoughts from yourself?
No, it's just that, we need to really think innovatively and out of the box sometimes to think of wraparound strategies that are going to support. And I agree that these kind of issues face young people in regional and urban centres. And this last case is a urban centre, I should point out, so it's not a remote case. Yeah.
Okay, well, thank you. So there's a little bit more information in terms of follow-up, but just mindful of time. So then, thanks everyone for joining us for this case study. I hope that you found it informative, and the discussion's been great with the panel. Great to see so many questions being asked in the chat box. So in terms of our next case study, so that's going to happen at the same time, Thursday, 23rd of March. We're looking at managing youth onset type 2 diabetes in adolescents now. Any feedback from this presentation for the next one, please email through to the youth type 2 diabetes at Menzies email. We're always interested in learning about how we can do this better. I want to take a moment to thank Angela, Stuart and Samaria and Emma. You know, it's been brilliant to listen to you all talk about these cases, and I hope that it's provided some learnings for all of our guests about managing type 2 diabetes. So thank you once again, and I look forward to seeing you at the next one.
Thank you.